Okay, thanks for those who are on time. I'm going to start now because it's quite a long presentation. So we can get going. Let me just see who's in the room. Good. All right, so tonight's talk is on DDH, as you know. I basically did this stuff every 2 years, but I don't think most of you can remember the last one, which was 2 years ago. So here we go. And there will be some cases and questions and so on throughout. So don't sneak away from your computer. I'll catch you. Okay, so let's just start with the terminology. If we're all ready to go. So the developmental dysplasia of the hip is a spectrum of pathology. And before I carry on, I just want to point out that dislocation secondary to other conditions such as cerebral palsy or other neurological conditions is not DDH. So it's a completely different pathology. The rules don't apply, and management's somewhat different than that for DDH. So the mistake I often hear registrars make is when they look at a CP hip, they start like talking about DDH classifications and management and want to do open reduction and stuff like that, and it's not really relevant. So this is a different, unique pathology. Okay, so a spectrum of pathology starting with instability, which we usually find in the neonates as the hips stabilize, usually in about 6 weeks. And this is when you're able to either subluxate or dislocate the hip. Then there's subluxation. This is usually asymptomatic, and it is a radiological diagnosis. When there's incomplete contact between the acetabulum and the femoral head, then there's frank dislocation, and then just dysplasia of the hip, which is again a radiological diagnosis, and it refers to abnormal development of either the acetabulum or the proximal femur. And so there's a little bit about the embryology. So normal development of the hip, the acetabulum and the proximal femur develops from the same mesenchymal cells, and they're actually only separated about 11 weeks of gestation. And that's why we often find that there's associated abnormalities with proximal femur and acetabular abnormalities such as proximal femoral focal dysplasia, where there's usually a degree of acetabular dysplasia or complete absence of acetabulum impact. So the head is maintained in the acetabulum during development by surface tension of the synovial fluid and the suction cup effect formed by the acetabulum and the labrum. Acetabular growth itself takes place through the triradiate cartilage. And it's important to remember that this is also a growth plate. So we forget that everything needs to grow. So obviously you can't have a tiny little acetabulum that doesn't grow. And where does it grow? It grows through the triradiate cartilage. So this is important to remember when we do our operations, because needless to say, if you damage the triradiate cartilage with your acetabuloplasty, you can actually promote acetabular dysplasia going forward. So there's 3 growth plates from the ischium, the ilium, and the pubis, and it grows by interstitial growth and gradually increasing the diameter of the acetabulum through. And proximal femoral growth. So when babies are born or during embryonic development, the entire proximal femur is cartilage. And then ossification center starts to develop. So usually the femoral head ossification center starts developing in approximately 4 to 7 months. This is always delayed in DDH, and you'll see that in some of the x-rays as we carry on. And there are 3 growth plates. This is something that I also always emphasize, is that this cartilage that you see here, like the circular cartilage, this is also a growth plate, because obviously the femoral head also needs to increase in diameter as it grows, and this is where that growth takes place. Then you've got the isthmus here, which is where the femoral neck grows in length, and then the greater trochanter, where there's some widening of the neck and then development of the greater trochanter itself. Okay, so in order for a hip to develop normally, concentric reduction is probably the most important factor. And damage to any growth plate, like I said, can cause abnormal growth. So this is not only ADN or mechanical damage to the proximal femur itself, but also to the cartilage of the acetabulum. So the pathogenesis of DDH is fairly complex and multifactorial. So genetics play a large role in the development of DDH. And we know that certain populations are more prone. And this is not purely due to their postnatal management of the child, for instance, swaddling or so on. is actually just a genetic predisposition. So there you see that so Africans and Southern Chinese are less commonly affected than, for instance, the Lapps and the Native Americans. But we also know that the European population, so your standard white Europeans, are far more prone to develop PDH than other demographics. About 12 to 23% of patients with PDH will have some form of positive family history if you delve deep enough. And this will then manifest as either acetabular dysplasia, and then with or without femoral neck anteversion and acetabular anteversion. So an adverse intrauterine environment can also lead to the development of PDH. So there's quite a few factors, but basically any condition that causes decreased intrauterine movement is likely to lead to DDH or frank dislocations. And that will explain why neurological conditions such as myelomeningocele or several of your myopathies are also prone to having dislocations or subluxation and dysplasia at birth. But we know there's the packaging situation or the small uterus. So the primigravidas, who tend to have smaller, tighter uteri, oligodamnios, breech presentation because they move less, multiple pregnancies with this less space deep, and then, like I said, any sort of decreased movement. And also we know that the left hip is most commonly affected, and this is due to the most common birth presentation, which is the right occipital anterior position, which leaves the left hip pressed up against the sacrum as the body descends down the birth canal, which then tends to, or has the ability to force the hip out of the joint. So ligamentous laxity is not a cause, but it is a predisposing factor. So there's a female predominance in DDH, and there's some theories that this may be due to the fact that females have relaxin receptors, and that's a hormone that gets secreted during pregnancy and birth, so that everything can relax. You know, the pelvis, you know, the symphysis and the sacroiliac joints all will enlarge the birth canal, the cervix dilates, everything relaxes. And females have those receptors, so this might make them more susceptible. And they also have progesterone receptors. So general laxity in an infant also places them at risk for further dislocation if other factors are present, but all infants are hyperlax. I mean, you know what babies can be. You can see how far their feet dorsiflex, how their hips go all over the show. So all babies are hyperlax. It's not a pathological feature. And DDH is interestingly not associated with our known hyperlaxity or collagen disorders such as the Stan loss, Marfan syndrome, and generalized ligamentous laxity. So the postnatal environment also plays an important role, and this is specifically has to do with the way that the child is carried around. So we know that swaddling is bad, and back carrying or carrying the child with the hips in the abduct position is good. And I love this little picture. Here's a little kitty with, I think she had Down syndrome actually at Maitland, who started carrying her dolls on her back like that. So it's ingrained in the culture, and that's very protective of the hip, in fact. So this was a study done in Blantyre by our friend Simon Graham. He's pretty omnipresent, and it was a retrospective study. So it's that the Cure Children's Hospital in Blantyre is the only dedicated pediatric orthopedic hospital in the country. And they just looked at their clinic visits, and there was 0 PDH. Yeah, so that's quite significant. And then also, because we know hip dysplasia and DDH predisposes to hip OA, they looked at the registries of a European country, in this case the UK, and the ratio between hip and knee replacements, and it's roughly equal. Whereas you can see in Malawi, they do almost 4 times as much knee replacements as hip replacements, which would also indicate that there's less hip dysplasia and therefore less hip OA. So it's not really a thing. And that's not only because of the back carrying though, but as we said, I think there is a large genetic component to this. So just carry on about the positioning. This was a study done in Hong Kong where it became slightly fashionable to swaddle the babies, and they saw a rise in the increase of hip dysplasia. And then they had this campaign in Japan where they promoted the Hong Kong position, so it's very fashionable now, and they decreased the incidence of DDH from 2 to 5, 0.5%. So it works. So one of the larger DDH registries in the world is the Swedish registry, and they identified several risk factors. So female gender is probably the most common risk factor, or the most important one. The presence of other congenital malformations such as metatarsus adductus and so forth, not actually clubfoot's not really associated unless there's an underlying neurological cause for both the clubfoot and the DDH, which would be things like myelomeningocele or arthrogryposis. Then increased maternal age and first parity is irrespective. We've mentioned that. Interestingly, maternal smoking was protected. I have no idea why. Full gestation, high birth weight was a respective breach, we know that, but only in natural deliveries, not in cesarean sections, and then certain maternal drugs. What they don't have here is a positive family history, but that is probably one of the major risk factors. So European female breech family history, you're almost guaranteed to have a DDH. So epidemiology, the incidence internationally is 1 to 2 per 1,000. Neonatal instability is much more common, but it resolves by 2 weeks about 60% of patients. There you can just see anyway, who gets it the most? Caucasians, then Native Americans, then Asians, then Africans. Female to male ratio is 4.1, anecdotally probably more. I think I've maybe operated on 2 boys in my career. And in South Africa, well, if you do a search for hip dysplasia South Africa, you're going to find quite a lot of veterinary websites. And then way down the list, you'll find something about pediatric human DDH. So it's quite common in certain dogs. Okay. No, that's it. So for the diagnosis, we all know this, but I think it's important to just cover it all again. So clinical diagnosis at birth would be with the Ortolani and the Barlow test. You cannot do these tests if the child's older. So I would say probably from about 3-4 weeks onwards, unless it's a frank dislocation, the hip's stabilized. So these tests aren't as sensitive anymore. And Ortolani is when you have a dislocated hip that you can reduce. And a Barlow is if you have a reduced hip that you can dislocate. So Ortolani hips are actually more pathological than Barlow positive hips because they are dislocated at rest. Then you can also see asymmetry in abduction. And so babies can abduct 90 degrees or more usually, and you may find it subtle, but there will be a decreased abduction on the affected side and then positive Galeazzi test. And this is one of my 2 male patients that I've operated on. This guy's got a blue heart, and you can see his left leg is involved, positive Galeazzi test, where the femur is short, and then also asymmetrical abduction with the left hip being less abducted. Okay, so now that's your clinical diagnosis. So let's talk a little bit about universal ultrasound screening. So I know we don't screen universally at all, and probably not remotely enough in the public sector, which is why we see so much late presenting DDH and so little early presenting DDH. So there was a Cochrane review done in 2011, which actually said that universal screening does not reduce the late diagnosis, but it increases the treatment. And there was some controversy at that stage because they felt there was a lot of unnecessary treatment. Obviously, there's a burden of cost. Parents have to travel back and forth. Public harnesses aren't free. They need ultrasounds. There's the odd femoral nerve palsy. There's the odd ABN developing. So doing more harm than good, really. They also found that targeted ultrasound was no better than clinical examination. And they found a reduction in treatment with delayed ultrasound, but no difference in late diagnosis. However, this is old now, so 12 years have passed, and this has been refuted. So this is not true. This is a far more recent article from Italy, where they did do universal screening, and that means basically like everyone, boys, girls, every single child gets an ultrasound. They found that of the 66 pathological, 66 to 2/3 of the hips that have abnormal ultrasounds had normal examinations, and about 20% had no risk factors, not even female sex. So the presence of hip dysplasia at birth is actually very high. So it's like 1 in 60, but it's not necessarily pathological. But the same study then found that they had no late presenting DDH in the first 5 years of life. So the argument will then stand that yes, universal screening does work. But is it justified if you have limited resources, or you know, in terms of the pie, how much of the pie are you really going to spend to prevent such an uncommon condition? And this was just another article looking at the question of universal screening, and they found that it might be time for a paradigm shift of screening DDH as a universal ultrasound protocol. It's a little bit rich because it comes from the NHS, and they certainly do not have the resources to do that either. So this is kind of the South African consensus, kind of the way we do it. So if you have a positive Bortolani or Barlow test at 4 to 6 weeks still, then you need it. If there's persistent instability, and then all your high-risk patients, so breech, females, questionable firstborn family history, and any other packaging abnormalities. So, for instance, we've had a little run of congenital knee dislocations in our clinic recently, and they have there's quite a high association with DDH in those patients too. So, anything that could predispose to DDH or be suggestive thereof certainly does indicate an ultrasound, but we're nowhere near doing ultrasounds for every female. So, I've got my little list of exam candidates here. So, Peter Botha, you're first up. So this is the first case that we're going to discuss. Peter, will you just unmute yourself?
Yes, huh?
Okay. So 6-week-old female, fourth child, normal vaginal delivery, no breech, floppy baby. So quite remarkable when I saw she was like popular, abducted, and so on. And she had a clicky hip on the right, and she was referred for an ultrasound on this side. So there's the ultrasound, and there are the results. Tell me what you think.
So right hip, clicky, alpha angle 43, beta angle 45. I know beta angle is supposed to be less than 60, and alpha angle is supposed to be greater than 60. So in that predicament, which you can see on the right, alpha's actually normal, beta's, I would also say, is small, less than 60, which is also particularly normal. I think left is also particularly fine.
So no.
Yeah.
So the alpha angle needs to be more than 60, like you said correctly, and the beta angle has to be
less than 55. Sorry, yes. Sorry, yeah.
So the alpha angle is grossly abnormal.
Correct, yeah.
It has to be more than 60. So this child therefore has bilateral pathological hips, isn't it?
Yes, but I'm confused because alpha angle is small, but beta angle should be greater. If the femoral head was dislocating, wouldn't the beta angle be increasing in size then?
I'm just trying, I tend to forget the exact numbers too, but I'm not writing my exam right now.
Yeah.
Sorry, give me a second. So I know, so normal value is alpha angle more than 60, beta angle less than 55.
55, yeah, correct, yeah, normal.
The alpha angles are abnormal, the beta angles are normal, but the alpha angle is probably more sensitive than the beta. So it's kind of like that argument, you know, if the screw is long on one X-ray, it's long. You know, so one of the angles is grossly abnormal, whereas the other one is maybe a little bit is within normal range, but you can't ignore the abnormal angle, even if the other one is normal. So this is indeed bilateral DDH. So we see 6 weeks. They're a little bit floppy. So what would you do with your concerns now?
I mean, 6 weeks, I would assess, and I would probably put into a Pavlik harness in this particular situation.
Talk about the Pavlik harness. How, in what position would you immobilize the hip? What's your protocol going to be? How are you actually going to manage this?
Yeah, sorry. So you got the Pavlik harness involves the anterior straps and the posterior straps. Anterior straps is particularly for flexion. Ideally, you want it between 100 to 110 degrees of flexion. The posterior straps are for your abduction strap, and your safe zone, I would say, generally say is between 30 to 60 degrees, more than 60, increasing your risk of AVN. And then obviously with the anterior strap for flexion, you don't want it more than 100 because they say it increases your risk of femoral nerve palsy. You place them into a Pavlik harness, you repeat ultrasound to assess If it's relocated, you reassess again at 1 week, do a clinical examination so there's no complications of pelvic involvement or disease, or pelvic complications, should I say, and then you repeat ultrasound. If it's still relocated, then I think you follow them up every 2 weeks. Generally with the pelvic harness, it's 3 months in total, but it's 6 weeks initially, and then you 23 hours a day for the first 6 weeks, and then you start weaning them off over the next 6 weeks. My understanding.
Yeah, no, you're confusing it a little bit with club feet, but you have the sort of the right idea. So it stays on for 23 hours a day until the hips heal. So I agree that 3 months would probably be where you give up. So even 6 weeks, if you've seen no improvement. So for instance, if you have a dislocated hip that remains dislocated, you would abort. And if there's no improvement in your alpha angle and your beta angle, you would also abort, because then you're not really winning, is it? But I'd probably give it a little bit more time than that. And then once your hip is normalized, we continue the pelvic harness full-time wear for at least 2 weeks, just to be sure. This is not particularly scientific, but this is a gut thing. And you'd rather like have them in the harness a little bit longer than risk recurrence or failure of treatment. But yeah, you basically have the idea there. Okay, so talking about ultrasound a little bit. So again, I know this is something we do a lot, but it's important to understand the anatomy. And I must say, it took, like, I had this epiphany probably like just before I qualified finally, when I understood what I was looking at when I looked at a ultrasound. So firstly, you must understand that it's a coronal cut of the hip. So you're basically looking at a slice of the hip in this plane at the level of the ilium. So there's your alpha angle, there's the beta angle. So if we turn it around to make it more anatomical, there's up, there's down, there's the ilium. And I'm going to show you a nice graphic now that demonstrates the anatomy a lot better. But there's the alpha angle. So you can see so this is the acetabular roof, sorry. So as the alpha angle becomes smaller, the hip becomes more dysplastic. So the roof becomes more open with a smaller alpha angle, and with a larger alpha angle. So if it's, for instance, it's 90 degrees, then that would be an acetabular index of 0, if you understand what I mean. So that's why a larger alpha angle is good and the smaller one's bad. Whereas the beta angle is the opposite. So as the beta angle becomes bigger and bigger, it means that the head is becoming more subluxed. So I'm just going to go through this. This is not such a nice ultrasound picture, but I got this from a German guy's PowerPoint that he shared with me. So just looking at it again, this is the picture that you're going to see on your ultrasound. That's going to be your alpha angle there, and that's the beta. But let me show you what that anatomy does. So I hope this projects very well, or fairly well, but that's the femoral neck. There's the head, there's the capsule, there's the labrum, there's the acetabular roof, there's the ilium, there's a little bit of fat, and there's the ossification center of the femoral head. So now if you interpose this picture on the ultrasound, there's your neck, there's the head, there's your capsule, the labrum, the acetabular roof, the ilium, the little piece of fat, and the femoral head ossification center. So just to reverse it again, try and imagine now what you're looking at. And then again, where the alpha angle is, that is it. So it will be the line of the ilium crossed by the line of the acetabular roof. And the higher the angle, the more flat the roof is. So therefore the more closed, and therefore the less dysplasia. Do you need me to go over this again, or do you guys think you have it? Oh, good.
Got it, thanks.
Got it. Thanks, Brad. Okay. So now, Peter, we're still busy. This is the same patient, age 6 months now. There was COVID. Fabric became too small, and it was abandoned. So now she's 6 months old. And now you can see on the right hip, the alpha angle is 60. So that's good. and the beta angle is 49, so that's still normal. But on the left, the alpha angle is still 49. This is a terrible ultrasound, by the way. It's not the correct view of the ileum, but we'll believe it anyway. And then the beta angle is now 78, which is way too high. So now what? Now we've got a 6-month-old with a corrected right hip, but a very pathological left hip. So what are your options now?
Yeah, so left hip is still dislocated. In this particular case, I would opt for at 6 months closed reduction, attempt a closed reduction in a public, and put him in a public, not a public harness in Sparker. In this particular situation. Yeah.
So we're going to talk about the closed reduction a little bit more later, but yes, that's what your option is going to be. And you could wait a little bit. I mean, 6 months is still very small. And you can wait a little bit until they're closer to like 9, 10, just a little bit bigger, before you attempt the closed reduction. But that will be the way to go next, yes. Okay. So beyond the neonatal period, the diagnosis changes a little bit. So unilateral, they'll come in with a leg length discrepancy, short leg Trendelenburg gait, asymmetrical abduction, and a positive Kaliatzik test again. Bilateral, often diagnosed after walking age because they're symmetrical, so they don't really notice the problem. And they've got a waddling gait and a hypolordosis. So I've had more than one patient refer to me from the spine clinic because they go to the spine clinic because of their hypolordosis, and then the DDH is picked up there because that's not first picked up. So it's just something to be mindful of. Okay, so Groenies, this is yours now. So it's a 2-year, 7-month-old girl, and she's had no previous intervention. So please just tell me what you see, and then I would like the differential diagnosis, because obviously we're talking about DDH. So just what's that gait, and what would be your diff? Oh, sorry, screen is here. Is he on leave? No, screen is not here. That means next on my list, I'm Maud. Come on, unmute yourself, please.
Yeah, I'm here. Sorry, it's a bit slow.
Fine. Okay.
So the video sort of quite jerky.
Not. This is how she's walking.
Oh. So initially it looks like, it appears to have a Trendelenburg gait. So you can see that pelvis, it's actually not very smooth on my side. It's sort of going from when she's in the front of the camera to the back of the room. But just if I have a look, I can see the as she's standing on her right leg, the pelvis is just have a look. Where's the left leg?
Which side is the Trendelenburg gait?
So her Trendelenburg gait is on the left. Yeah, on the left side.
What's your differential diagnosis? So probably bilateral DDH, because that's what the talk is about. But or unilateral. But what would be the diff for a Trendelenburg gait in this age patient?
So like we said, yeah. So DDH in this case, and then as well, so other defective hip abductor mechanism. So she have proximal, just one, yeah. So and then just one.
What else can give you a short leg Trendelenburg gait in a child?
Yeah, so she have any other limb length discrepancy is one. And then
Remember that though.
I suppose that would give you more of a short leg. So other proximal femoral dysplasia.
What's proximal femoral dysplasia?
Sorry, it's
That's
breaking.
not
No, sorry.
diagnosis that I'm aware of.
Just breaking up a bit. Bilateral cox, yeah. So bilateral coxavera.
Good, yes.
And just get now. And let me just think. I don't know why I went trying to think what else.
Coxavera is probably the
Yeah.
answer I was looking for the most, is bilateral
Yeah.
coxavera, but then anything that will give you a
Yeah, so
dysfunctional
any other,
AVN
yeah, any other
following.
epiphyseal dysplasia, yeah, AVN,
Yeah.
post-traumatic, yeah.
Yeah, but the what I was looking for was the coxavera, yes. Uncommon, but important. Yeah. So in fact, she has bilateral PDH. And if you just look back at this video, if you look at her shoulders, she has a bilateral Trendelenburg gait. She's walking like a windscreen wiper. But it is worse on the one side. It looks like her left leg is a little bit longer than her right leg. And that fits in with the picture where the degrees of dysplasia. Right hip is definitely worse than the left. But it is, in fact, bilateral. So what would you do for her?
So for her, just what was her age again? I just sorry, I'm losing you going soft. She is
2.5
years old.
2.5.
2.5. Yeah, so in a 2.5-year-old patient, so she's gone past the age for non-operative management. So she would require surgery at this age. It would likely require sorry?
Be specific. What are you going to do? Yes, she needs an operation. What are you going to do?
So she needs open. So on these X-rays, we can see that both hips are dislocated. They're out of the Helgenreiners and Perkins lines. You can see in the upper outer quadrants. So she'll need an open reduction, and likely a femoral varus derotation osteotomy in her.
You need a varus osteotomy. Or the hips abnormally valgus. Is that typically what we do for PDH?
Not yet. So she's not extreme valgus. So we need to reduce the hips on her side. So she does have an increased acetabular index as well. So we can, if the articular cartilage is preserved, so we can do a reorientation osteotomy to increase the lateral coverage.
So basically, she needs open reduction, femoral shortening, and some form of acetabular osteotomy, whatever your choice is. So you just did that thing that I warned you about. Patients with cerebral palsy gets varus derotation osteotomy, not PDH. AP derotation. Okay. Anyway, so we did that on the one side. We've done the other side as well, but I can't remember who this patient is, so I couldn't find her X-rays. But there she had exactly that. She had a Daigo open reduction, and she actually then ended up not needing a femoral shortening, which was unexpected. Okay. So diagnosis on the X-ray. So it should be fairly obvious, but if the femoral heads are not ossified, it can be less clear, as in this particular case. So you draw Hildenreiner's line, Perkins' line, and the superior acetabular margin, and then you also look at Shenton's line. And then there's some classification systems. So there's the Tonnes grading, which is a grading of severity. So grade 1 is essentially normal. Grade 2 is lateralized but not proximalized. 3 slightly higher, 4 completely out. And then the other classification is the IHDI classification, which is very similar to the Tonnes. So either or, I think Tonnes is an older classification, but I don't really think there's a big difference in which one you use. And this is I suppose, relevant to a certain degree when you decide what treatment you're going to give. So if you have a tonus 4, you're more likely to need a femoral shortening than with a tonus 2. But it's also useful for research purposes in terms of prognosticating. And so we know that the worse the hip is, the worse they do. It's obvious, but I don't really like classifications. Then we look at the established, the other measures, radiological measures on the X-ray. So the acetabular index is an important feature that we look at. It's probably the most commonly measured angle in my practice, because that tells me should I or should I not do a pelvic osteotomy in addition to the femoral osteotomy. So we know how to draw the lines. We must draw the Reiners lines first, otherwise you often get oblique X-rays that can alter your measurements. And normal in a newborn is about 25 to 30 degrees, less than a year, 20 to 25, and 2 years and older, actually about 15 to 20 degrees, it's low. So normal in an adult is approximately 18 degrees. So if you have a 23, 24 degree acetabular index, that is actually dysplastic. And then you would also see an underdeveloped teardrop. So if you look on the normal side here, that's quite a nice little teardrop. It's very nicely shaped. Here, there's nothing. And that's because the acetabulum is actually, the medial acetabular wall is thick because there's nothing inside that's grinding it away or molding it into its normal shape. So then there's some other measures. So the center edge angle, which you can only use if you have a spherical femoral head. So if you have an unossified femoral head, you cannot see where the ball is. Therefore, you can find the middle of the ball. And so this is a measurement that's used in older patients and adults. That's the center edge angle. And it basically measures how much of the acetabulum the femoral head is using. So it's not necessarily an independent measure of acetabular dysplasia, but more of the relationship between the femoral head and the acetabulum. Can only use them more than 5, like I said, and their normal values is more than 15 degrees in the younger kids and more than 20 in the older, like in the adolescents, older than 14 degrees. Okay, so that's that. And then subluxation, we can quantify by firstly looking at Shenton's line, whether or not it's intact, and then the Reiners migration index, which was originally described for cerebral palsy and actually has very little value in DDH, but it's still, if you want to quantify the degree of subluxation, then that's one way of doing it. Okay, Peter Venter, are you here?
Yes, yeah, hello.
Hi. Okay, so this is your case. So this is now a 3-year-old with this
10 months
situation.
old.
No, 10, sorry, it's case 3, 10 months old, sorry, with this situation. So just tell me what you see and what you think you're going to do for this patient.
Okay, so it's a AP and a frog leg of said patient. The left side is deficient with acetabular index also more than on the right, although slightly. The right side isn't completely in the inner lower quadrant that what you wanted, but at this stage the most pathological one is the left. I think that on the frog leg it also, the right side is normal. So this being a 10-month-old is quite young still. It's probably it's just before starting to walk. So I think at this stage, because she's way too old for public, I would attempt a closed reduction of that left one, closed reduction in spica.
And is there any surgical procedure that you would combine with the closed reduction?
So you can do an arthrogram. It's not surgical procedure as such, but if you want to see, it's also a prognostic value. You can do an adductor tenotomy as well. If there is excessive abduction that you need to put it into to maintain your reduction. I mean, if you look at this, it's not really contributing to it being reduced on abduction. So maybe not necessarily. I mean, that's an intra-op decision that you have to make as well. But at this stage, I think only the left needs treatment.
Yeah. So yeah, the adducted anatomy was what I was looking for. So I have a relatively low threshold of doing it, unless the child can abduct to like 90 degrees without the adducted anatomy. And you can kind of see there's less abduction on the left here than on the right.
Yes.
Yeah, even in the X-ray. So that's exactly what we did. And I just want to show you this because these are nice, nice arthrogram pictures. So there's the hip. You can see it's not completely out, but it's lateralized and there's significant dysplasia. So then we do, sorry, this is, oh, sorry, never mind. I was just suddenly confused about which patient I was looking at because Chronis's absent has messed up my system a little bit. Okay, but now there you can see it's quite a nice picture. And you can see how much acetabular roof there actually is. So that is all cartilage, it's not nothing. And if you use that to measure your acetabular index, then that would probably look fairly normal. But there is medial pooling of the dye, and which improves with abduction in the frog leg position. You see that's a lot better. And then at this point, I also just want to point out something interesting that I've learned recently, or that was mentioned in a talk I attended, is that this cartilage you see here, or you don't see here, as with any other cartilage in the growing skeleton, is a growth plate, isn't it? So if you have a decentralized or slightly dysplastic hip on the X-ray, it means there's already abnormal ossification of that. Where I'm pointing with my finger, but you can't see. There's already abnormal ossification potential of that acetabulum. And now, if you think about our Voigt-Volkmann principles, if you have ongoing eccentric loading of your abnormal cartilage of the acetabular roof, it will not grow because of the increased pressures on it. So slightly eccentric loading on abnormal cartilage, decreased growth, progressive dysplasia. And that's why, even though the arthrogram shows us, oh, there actually is cartilage there, you would often still do an acetabular osteotomy to basically squash it down even more because it needs help. But that's just an interesting concept in this. Anyway, so then we did.
Sorry, Anria, can I ask something about the arthrogram there, please? So when you measure the dye pool, the medial dye pool that they say mustn't be more than 5 or more than 7 millimeters. So where do you? So yeah, so they say it mustn't be more than a certain amount, but how do you measure that now? So it outlines the head, but do you go from the medial acetabulum?
Yeah, so I go from the triradiate cartilage, yeah.
Okay, all right.
So around about there. And that measurement that that you're talking about is probably more relevant in Perthes, is when we look for hinge abduction. Is to see if that medial pool increases. But it's basically there shouldn't be any medial pool. In a concentrically reduced depth, there should be no pool anyway. So that just shows us that there's not a congruent articulation between the proximal femur and the acetabular. But yeah, medial. Okay, so now this happened to her. So we did the close reduction adducted anatomy, total of 3 months in her abduction spica. And now we can see there's some improvement. So Shenton's line is now intact where it wasn't. So these were original X-rays, and you can see Shenton's line is broken and she's quite lateralized and so on. But are you completely happy with this X-ray? Do you think, okay, fine, cured, discharge? Or is there something that still concerns you a bit here?
Okay, so the left-sided ossification nucleus is smaller, which I think you can expect with a more pathological hip. The problem is the acetabular index is still quite on bony index is still quite steep opposed to the right side. So I just want to see. Yeah, so it's still at risk of dislocating because the necks are quite valgus as well still, because the child hasn't started walking.
The neck valgus is normal at this age, so we're not too concerned about it because you can see it's the same. But the
Okay,
fact
yeah,
is
yeah.
there's still acetabular dysplasia. So now you can then put the child in an abduction brace and see if that helps. But essentially at this stage, I usually give up. I tell the parents, listen, the hip's in, it's looking good. I'm going to keep monitoring her, but I'm probably going to have to do acetabular osteotomy at some point. And I've done that a few times where I let them go like this. They're not sublux, but they remain quite dysplastic. And then when they're about 2, you just do your DAGA, which is then a far lesser intervention than having to do a whole open reduction story. So you still save them some of the surgical burden, but that's unlikely to correct spontaneously. So yes, you will not discharge her. You'll continue following her up.
And Anria, specifically for the DAGA, is that as a acetabular-plasty, is that your go-to, or I mean, the reorientation osteotomies, and though it's just because it works well, it's got a predictable outcome?
It's just my preferred method, and it's like a DAGA / Pemberton, but some other people are more comfortable with the Salter. The thing with the Salter is you need internal fixation of some sort to keep your wedge. And then frequently that needs to be removed. So that's one downside of it. But otherwise, it's really just a preference thing. They work equally well. Well, not quite. I'll get to that. But I prefer an acetabular-plasty. Let's just stick to that because you sort of use a combination of the two. Yeah. Thanks, Peter. Well done. So there's the arteriogram. Yes, it's useful during close reduction to identify blocks to reduction. So in this picture, so the ones I showed didn't have any of these pathological features because it was quite a mild case. But here you can see there's the inverted labrum, there's the ligamentum teres, there's your psoas. So it just shows you a little bit more information, and it can show you again, look at that. Look at all that acetabulum that you can't see on the X-ray. But this is almost as dislocated if there's a lot of dye in the joint, and I don't think this hip will reduce close, to be honest. That's from a book, so I don't know. Okay, so the natural history of DDH, it's got a variable course. So from birth, 60% stabilize in 1 week. We said 88 in 2 months. So that's almost, so there's 12% left of the pathological hips at birth. So and that will be your true dislocations in the end. So treatment is indicated for instability that persists beyond 4 to 6 weeks. I think I have mentioned this. I should probably remove that slide. The natural history in adults, bilateral dislocations is fairly favorable. It's not great, and definitely not in our modern society where everybody has to be perfect and live until 90. But as a symmetrical gait, they do get lower back problems in the end because of the hyperlordosis, and of course because of the decreased range of motion in the hip. If they have a false acetabulum, they have a poorer outcome. But this is one of those classic X-rays that you find in basically all the textbooks, where the 65-year-old male presented with his back pain, and they found this bilateral DDH that he's had his entire life and was never diagnosed and never bothered him. Unilateral DDH has a much worse prognosis because of the leg length discrepancy. They develop scoliosis, initially postural, obviously it can become structural, hip adduction contractures, knee valgus, and that's not a good situation. So the sort of pervasive wisdom is that you would treat a unilateral DDH until the age of 8, after which you're more likely to do harm than good, and a bilateral until the age of 6, after which you're more likely to do harm than good. So again, it's impossible to have long enough natural history studies to actually scientifically confirm this, because we don't leave DDH alone anymore, and we seldom see such late presenters. But it's just because the prognosis for a unilateral hip is so much worse than for a bilateral one. So if I see a 7-year-old with bilateral DDH, I'll just leave it alone. Okay, as for the dysplasia, why do we care? Why is it the topic of the century or the decade so far as hip dysplasia? Everybody wants to do a scope and a PAO and so forth. It's because it leads to osteoarthritis. So you have increased contact stresses here at the outer part of the acetabulum, which leads to labral tearing, eventual and relatively rapid cartilage delamination, and OA in the 4th decade. And that sounds like, oh, that's not so bad, but we are all in our 4th decades, except for me, then in my 5th decade, me and Peter. So we're young. We don't want hip
Thank you,
replacement
Anria.
right now. Is it this? Anyway, okay. So management, we've spoken about a little bit with the cases, but basically it's like a spectrum, you know, from the very young to the very old, almost like femur fractures. So public honors, closed reduction, open reduction. I wrote VDRO. I'm sorry, it's not a VDRO, it's a shortening osteotomy. It's a mistake. Pelvic osteotomies, and then of course all of the above. But basically you do what you have to do to obtain and maintain a concentric reduction. That's the rule. So regardless of the age, that is the aim. Yeah. So just briefly on the management. So all unstable hips less than 6 months get a public honors or some form of abduction brace. So we use the public honors. That's just what we do. But there are other braces available, like the Otterbock and the whatnot. Roughly 90% success rate in the management of autolani positive hips, which is the worst ones. Correct application, patient education, like Peter Berta said, you know, there are risks involved, although very low. The femoral nerve palsies and avascular necrosis. And then 2 to 6 weeks after clinical and ultrasound stabilization and normalization of parameters. So there's no set amount of time. It's until it comes right, or if it doesn't, you abort. And we've gone through all of this. This is just how you put it on. Monitoring treatment. Peter also correctly basically said all of this, and then just watch out for skin issues and nerve palsies. And this is just some systematic review that looked at the outcome of the treatment, and the pelvic harness doesn't actually do that great, hey? So compared to some of the other splints. So still 11% failure rate using the pelvic harness, 5% OEN was already okay. Residual dysplasia, 9% residual dysplasia. That's it. So this is the Van Rosen splint that they talk about. I've never used it, but apparently it works really well if you believe this study. And I think maybe it's also easier to apply because you just like hook it on. You don't have to adjust the straps and so on. So that may well be why the pelvic harness failure rate is so much higher, because it's slightly technically harder to do, even for orthopedic surgeons. Okay, closed reduction. So the indications will be paid pelvic harness treatment and all presentation beyond the age of 6 months. So some people do skin skeletal fraction pre-operatively, or it can be advocated. You might read about it. It's not a thing. It doesn't really work. And it's also not practical these days with the push for less inpatient, more outpatient type. So just operate. Adductor longus or psoas stenotomy at the time if you want to check your reduction. So that's always tricky with the X-ray alone, especially if you don't have an ossified femoral head. So MRI is really the best way to do it, but not practical, of course, in our sense. And then we do a plaster change and arteriogram at 6 weeks. And this is firstly because the cast gets dirty, the child's growing. So you need to change it. And that can also just check that you're actually getting some improvement with your treatment. Because if, for instance, after 2 or 3 weeks or 6 weeks in the spica, the hip is still out, you won't put on another one and just leave it and then come back with your next level intervention. Which comes, and then after the 3 months in the spica, then for the closed reductions, and I sometimes still put them in the abduction brace for another 6 weeks. And this is just another study looking at the closed reductions, redislocation in 14%, ABN 15%, residual dysplasia 17%. So it's not great. And this is also what you should counsel your patients about. You see them is that you can do this. There's an 80% chance that you'll avoid the need for surgery to do it, but that's still the 20% chance that you will still have to go and operate, and there's even more time in the spica and etc. But it's worth a shot. And then risk factors for failure is, of course, higher grade, older patients walking, and actually bilateral as well, which is not there. This is just another one looking at the same story and basically the same results, 50% failure with the same risk factors. Okay, who's next? It's next, Dane. Dane.
Yeah, Bo.
Okay. So 16 months old, so 1.5 year old now. This is the situation, and this is incidentally the same patient that Peter had in his first one. So now we've got the situation, 16 months. Tell me what you see and what you think and what you're going to do.
So epipelvis of the mentioned child, we can see the left hip is dislocated. There's an absent or barely visible femoral ossification center, femoral head ossification center. It might be a rotational thing, but the neck rather looks very valgus. And there is acetabular dysplasia, and a pseudoacetabulum is developing there in the left ilium. So it's a tonus or an IDHI4, or the worst kind at least. And then just because you mentioned that is Peter's case, was that the one with bilateral ones? So the right side is, sorry, I'm just trying to reorientate and draw these lines in my head. The right side is obviously better, but it is not normal either. It's going to be on the sort of Hilgenreiners or bisected, and it's more lateral than Perkins line. So it's going to be a sort of moderate grade, if I can call it that for now, without putting my head on the block. Are we going to carry on for treatment, or is there something I'm missing?
No, you're right. Yeah. So frank dislocation on the left and the abnormal right side. So probably a grade 2 to 3 subluxation without significant dysplasia on the right, but the hips unstable. Yes.
Yes, acetabulum looks okay. So she's had 2 failed closed reductions on the left, so we're going to talk about an open reduction at this point. You might want to wait until she's a bit older. I think we're usually aiming for around 18 months, but if you've tried twice already, I guess she's heading that way. So I would advocate for an open reduction on the left side, where you need to do an anterior approach to the hip and address your intra-articular and extra-articular blocks to reduction, which I can go through if you want, and then plus minus a femoral shortening osteotomy. Basically, you want to try and reduce the hip with one finger pressure, and if it's anything more than that, and if you're going to stuff that hip in, then you're going to risk increased chances of AVN. So it's likely going to need a shortening osteotomy in this case, since it's already had failed closed reductions twice. And then if needs be, you could then address the valgus hip if it's necessary, and you would measure your acetabular index and then do a acetabuloplasty. As we've said here, traditionally we do a Pember-Dager type osteotomy to close that angle, and then reduce and spike a cast in a stable reduced position, abduction and flexion essentially.
Okay, good. So turns out she didn't need a shortening again, but she did need a Dager, and that was a post-op X-ray. So we sort of managed to treat the right hip automatically with a closed reduction because it wasn't a spike with the left hip. So that actually worked out quite well in the end. Yeah. Shame, but this wasn't such a happy story, just because I always have to tell you my sad little anecdotes. So this baby had Prader-Willi syndrome, which is why she was so floppy.
It was floppy,
and
yeah.
Else, yeah. And shame, she died of pneumonia, I think, like less than a year after I did this. Completely unrelated, but shame, man. Anyway, I was quite sad. She was incredibly cute. Okay, so good. Yes, open reduction. So we do that. Patients older than 6 months usually wait until they're a year, just so that they're bigger. So if the closed reduction fails, so for or redislocation or inability to achieve a reduction in the safe zone, which is like less than or 60 degrees or less of abduction. So I prefer the anterolateral approach, which is actually the Salter approach, because you do an iliac split, iliac hypophyseal split as well in order to access the hip properly. Some people do the medial approach where you go through the groin. I've never done it. I have no experience in it. But the problem with that is that you can't do a capsulorrhaphy. And if needed, you cannot address the acetabulum through the same incision. So I just stick to what I know. That's what we teach and that's what we do. So the blocks to reduction, like Dane mentioned, There are intra-articular and extra-articular blocks, and all of these have to be addressed systematically in order to ensure success. So the extra-articular ones is the psoas, the adductor longus, and the hip capsule itself. And then the intra-articular ones is the ligamentum teres, the pulvinar, which is the fibrous fatty tissue that's in the acetabulum because the femoral head isn't there. Transverse acetabular ligament that's contracted, and the inverted labrum that's in the proximal part of the femur. And then just another practical point. So several people do a percutaneous adductotomy. I don't like it because the obturator nerve is right underneath the adductor longus. So you either do an incomplete stenotomy or you will cut the nerve. So just do it open, it doesn't add much. There's some pictures just to brighten up the presentation a little bit, but I won't linger on this. Hopefully you will all see it during your time at Maitland, but there's the capsular artery. Okay, and then post-operatively, we change the spike at 6 weeks, 12 weeks in total. But then there are complications as with anything else. Redislocation is the most dreaded complication because once you've had to go back and redo an open reduction, it's a world of hurt. The tissue plates are scarred, everything's small and stuck down and sticky. It's very unpleasant. And then AVN. So when do we add osteotomy? And you have two options, of course. You've got a femoral osteotomy and you've got a pelvic osteotomy. And we'll go into them some more. And note there varies, I said almost never, because it's very seldom needed. And what you see often is the rotation on the X-ray. Once you correct the rotation, you'll see there's actually normal neck shaft angle. Okay. So this is my algorithm, which is kind of intraoperative decision-making process as you go. So you do your whole open reduction, systematically address all the blocks to reduction that you get. Is the hip reducible? Yes or no? Yes, and like I said, a single finger, if there's a grunt coming out of you when you push that hip back into the hip acetabulum, it's too much pressure. So it must go gently in with your fingertip. If it's not, you must do a femoral shortening. Then you go back to your stability testing. So now you've got your hip reduced, you've taken away the blocks to reduction. You place the patient in the safe position, which is 60 degrees of flexion, 10 degrees of internal rotation, 30 degrees of abduction. They also call it the human position. I'm not really sure why, but if that comes up somewhere, that's what it means. So that's your stable reduced position. Now you want to see where is the deficiency. Is there something you have to add? If you extend the hip from the fixed position and it pops out the front, you need anterior cover, and that would be a pemberton osteotomy. I'll show you some pictures now. If you adduct the hip and it comes out the side, you need a dagger because that gives you lateral cover. If you externally rotate the hip and it comes out, then you need a femoral derotation. And that simplifies the matter for you. And then you know what you have to do. Easier said than done. So there's just some examples of femoral osteotomy. So look at this. This is the same hip. And then once you put it in its maximum abduction and internal rotation, you can see that the anatomy of the proximal femur is actually not abnormal. It's the position. It doesn't really need much of varus. They did it anyway, but with a nice outcome there. That's also from a book. That's not one of my patients. Okay, so what does the osteotomies do? The pelvic osteotomies, it improves acetabular coverage. We know it's more effective than a femoral osteotomy to improve acetabular coverage because it addresses the acetabulum directly. Whereas a femoral osteotomy, you're relying on remodeling to occur. And as we know, or as I said, there's already pathological cartilage and pathological growth. So it's unlikely to happen. So there's two main categories of osteotomies that we use for DDH. There's sort of redirectional osteotomies, where you don't change the shape of the acetabulum, but you change its orientation to provide better cover. The most common one in children here is the Salter, which we don't really do much of. Then there's a steel triple pelvic osteotomy that we do in older children, and then the Duns osteotomy or the periacetabular osteotomy, which I cannot do, but is a very powerful, effective, but difficult procedure for older children. Then there's the acetabuloplasty, where you actually change the shape, and that is the dagger and the pemberton, or the combination of the two. The brief mention of the Salter. It's internationally, it's probably one of the most frequently performed because it's relatively easy. you just expose the ileum, find the sciatic notch, use a jiggly saw, take a piece of bone, wedge it in there. It's not a very difficult osteotomy, but I think as a result, people underestimate it and sometimes get it wrong. It provides about 25 degrees of anterior cover at the expense, and I think that's meant to say lateral, 15 degrees of lateral cover. It hinges on the symphysis pubis, which obviously limits until which age you can do it. So they need a mobile symphysis, so 6, 7 about is the end of that. And you'll do it at the same time as an open reduction or as a later procedure if there's persistent dysplasia. And this is just a picture. So there you can see you've got your jiggly saw there in the sciatic notch. You come out just underneath the anterior inferior iliac spine. And then you use your laminar spreaders or whatever to open your osteotomy. You cut a wedge of bone from the top there. You can also take out a V-shaped piece of ileum there and you stick it in. But this is not inherently stable because you've got like these wafer thin little pelvic bones that you're relying on. So you do require some form of internal fixation, usually threaded K-wires, which can then be removed in a later stage. And there's some pictures. Work very well for this patient. This is the steel. This is also from the book. Hopefully, with next time I get this talk, I can show you my own X-rays. So they're slightly older. You still do the salter, but you can't hinge on the symphysis. You have to cut the ischium and the pubis as well. This is the guns. So again, all 3 bones, but the posterior column of the acetabulum remains intact. So it's a lot more stable. And the patient can walk immediately. And because you're closer to where the actual deformity is, just like with any other osteotomy rule, the closer you are to the fora, the more correction you can get. And it's exactly the same here. So with the triple, you're far away from the center of rotation, whereas this closer, so it's more powerful. Pembedega osteotomy, Pembedega, whatever, semantics, is basically it's an incomplete osteotomy. It hinges on the triradiate cartilage, and you get various degrees of anterior and lateral cover depending on where and how you shape your osteotomy, basically. And that's indicated for marked dysplasia where the hips reduced, but it's not concentric. Yeah. And there's just some pictures. So you see the pemberton gives you more anterior cover. So the cut is more anterior and the dagger is quite lateral and gives you that sort of more lateral cover. Okay, so then somebody did look at which is the best. So salter versus dagger versus pemberton. This is again a systematic review. And alas, when we look at the Severin criteria, and I'll get to that, but the Severin criteria is a radiographic grading that's applied at skeletal maturity. So the favorable Severins, the pembertons did the best, followed by the daggers and followed by the salters. So they did, in terms of this systematic review, in terms of your favorable results, the pembertons did the best. And also the same when they look at the McKays, it's a clinical score, not radiographic. And again, the pemberton seems to win. So there. Okay, salvage osteotomies is if it's too late, you can't change the orientation of the acetabulum anymore. If there's, I'm going to say, already proximal femoral changes, like in here we've got coxoplanar, looks almost more like a post-Perthes hip. Then you can expand the size of the acetabulum literally by building a shelf on the outside, and it gives you that situation there. And then a Chiari, kind of doing the same thing but a different way, is that you cut the superior, the roof of the acetabulum, and you medialize the entire acetabulum relative to the ileum, and thereby create enlargement almost of the articular surface. Although you're then not articulating with cartilage, but with your capsule. So salvage osteotomies, you will never do that as a primary intervention. Okay, so let's talk a little bit about avascular necrosis or growth disturbance, which is a preferred term for this, what do you call it, this phenomenon. So it's the most common complication of DDH surgery. You'll never get it if you don't operate or if you don't intervene. It's not part of the natural history. You can get it with fabric harness, but it's mostly following surgery and seen with all forms of treatment. The risk increases dramatically after the age of 18 months. And I think that's just because everything's just stiffer and harder to treat. And it compromises the success of your reduction and your final outcome. So it's classified, of course, by Buchholz and Ogden. This is my preferred classification. There are two others I'll show you, but I won't go into details. And basically, it's relating to which growth plate's affected, or which part of the growth plate. So the grade 1 is if the femoral head growth plate, so you know the actual head, that's affected. So the head is small, but it's still round and it's still congruent. So we didn't really consider this a complication. It's just, you know, it's more like a radiological observation, but it doesn't have any clinical bearing on the outcome. And the type 2 is where you have arrest of your lateral physis. So you get progressive valgus deformity, as you can see here. Shenton's line is broken. There's an increased neck shaft angle. There's uncovering of the femoral head, so they get late dysplasia. And this one catches you because you think they look nice, and then you discharge the patient and they fall because everything looks so great, and they come back at 9 with the sublux valgus hip because of this. So if it happens, you do a varus osteotomy. In the grade 3, the entire physeal plate's arrested. Therefore, you get coxa breva, so a short femoral neck with trochanteric overgrowth. In this particular case, there's also a significant acetabular abnormality, but we're just looking at the proximal femur now, ignore acetabular. And then finally, the grade 4s, you get medial growth arrest with progressive varus formation. This is not the worst case I've seen, but you can see that neck shaft angle is more varus than the other side. Southern requires intervention, but you can do a valgus osteotomy if it is if it is significant. Then there's some other classification system, Columbia, McEwen, and Salter. I think if you know one, that's probably enough. And even if you just know it exists, because I didn't know about this when I was a reg, so consider yourself lucky. Okay, who's next? Selma. Is Selma here?
Yes, I'm here. Sorry, just took a while
Good.
to.
Okay, that's okay. All right, Selma. Look at this X-ray. Give you the whole story. Don't bore me with it's an AP and all of that. Just tell me the diagnosis. What the radiological features you see, and what are you going to do, bearing in mind the patient's age and so on.
Okay, 3.5-year-old, 3.5-year-old child. X-rays show bilateral hip dislocations. Yeah. I think with possibly a little bit difficult to see what's going on with the femoral heads, but yeah, the main thing is that they're both dislocated. Can't necessarily appreciate a pseudo acetabulum there, but yeah, I can't actually can't say much about the acetabulum, but it does look dysplastic. We still have maintained varus, so to speak, of the femoral head, the femoral neck shaft angle, and I can see the epiphysis bilaterally, even though I think medially it seems a bit dysplastic, if I can use that word. Yeah.
Slightly abnormally shaped, yes.
Yeah,
But,
yeah.
Yeah. Bilateral dislocations looks like relatively normal proximal femoral anatomy, acetabular dysplasia, 3.5 years old. What are you going to do?
For this patient, I think surgical intervention is necessary. We'll most likely need a bilateral pelvic osteotomies, and definitely proximal femur shortening, I think. Yeah, in this case, for my limited knowledge at the moment.
Limited knowledge. I've just been giving you a touch for the last hour and 15 minutes. So
Yeah.
you missed the crucial step, which is the open reduction. So open reduction.
Open reduction, pelvis osteotomies, yeah, and then most likely shortening of proximal femurs bilaterally to centralize that femoral head bilaterally.
Simultaneously, would you do it in one sitting?
It is a huge surgery.
Yeah.
I would. They say that one stage, doing it once is better than doing it at 2 stages. But if we are going to go for shortening and pelvis osteotomies, we'll have to go according to the patient's clinical picture intraoperatively, I think. If the patient is still okay and we have minimal acceptable bleeding, then I would do it simultaneously at the same time. But other than that, if not, then we'll stage it.
So we usually stage it. I've tried doing it sort of like 2 weeks apart to minimize the time in the spica, and that didn't go very well. I've never tried doing it bilaterally. I think it's too much. These children are small. So, I mean, if you lose 300 mils of blood in the skid, then that's like a third of their blood volume almost. So we do usually stage it, and we let the one side sort of recover completely before we do the other side. It's just that sort of technique is developed over time with that protocol. Anyway, so now this is her 2 years later. Now, what do you think happened there? Well, anyway, just tell me, what do you think of this X-ray? What was the diagnosis? And then what would you do? What do you think you should do?
Okay, so 2 years later, the hips are reduced, but I can see signs of what looks like AVN. I'm sorry, the picture's not projecting very well on my PC here. It also seems to bilaterally have coxa. I can see changes in the acetabulum mostly on the left compared to the right. Yeah, I'm not very convinced of AVN because the femoral heads sort of look similar to what they were when we operated. So I'm not actually seeing any sclerosion or fragmentation, anything like that. But the main thing for me is the coxa here.
Why does she have coxa? Especially on the left. She didn't have coxa when we started.
Yeah, no, she didn't have coxa when we started.
Why does she have it now?
I think possibly because the growth plate it doesn't look closed here, but she may have overgrowth of the where are we? What's going on? Okay, wait.
Growth arrest following treatment.
Yes, I'm thinking of growth arrest, yes, but you can still see the visual line there, but that I would assume that's what had happened. Growth arrest and basically overgrowth of the trochanteric region.
So what grade would this be? Now, the Ogden classification.
This would be, let me see, grade 3 or 4. Grade 4 would be a grade 4 because there's various.
So she's got,
yes.
Yeah. So there's various. Yeah. There's a rest of the medial phases. You can't see a bar, but there's growth disturbance there. It has to be because I didn't put her in Bevis. Okay, and now what would you do?
This is where
possibly do to address
that. Possible valgus osteotomy.
Good. That's what we did. Okay, and this is the last X-ray, and then she's disappeared back to the Northern Cape, where she came from, and I haven't seen her since. But I hope that's because they're so satisfied with the osteotomy. Okay, thanks, Alma. So, right, so AVN, again, just focusing on that a little bit because it's a common complication. So more severe dislocations got a higher risk with dysplasia, increased age. So it almost exponentially increases the risk of AVN after the age of 18 months as they get older. Doing a medial approach, and I think it's because you roger that medial circumflex femoral artery to do that. And then obviously the more times you try, the more damage you do, etc. So that's why I said, you know, the redislocation is probably the most dreaded complication here because then it's like opening up a world of hurt. Okay, let's briefly about the Severin classification. So this is actually a classification I like a little bit. It's awarded at skeletal maturity. It's similar to the Stulberg classification in Perthes in terms of basically it looks at what you've got left, what's the outcome of your treatment as clinical maturity in order to prognosticate. And it's useful when you're evaluating different treatment strategies, because every X-ray looks nice, you know, intraoperatively, but it's children, we care about what's going on by the time they're grown. So it incorporates dysplasia, proximal femoral shape, subluxation, etc., and higher grades associated with more osteoarthritis. And this is it. It's fairly complicated the way it was described here, with a lot of centroid angle measurement. And again, so remember we said you can't use the centroid angle in a young child because there's no ball, you can't see the middle. So this is at clinical maturity, so 14 years about. So group 1 is basically normal. Grade 2, there's some abnormality, but it's contained. So you might have coxa breva or something, but the head's congruent and they usually do very well. 3, there's dysplasia, but no subluxation. 4, subluxation, and 5 and 6 basically dislocation. So that's a classification. And we're very nearly finished. And then lastly, Brad, this one's for you. And sorry, you just made it onto the list because Clunis is absent. I have to take it up with him. Brad, you still here?
Yeah, I'm here.
Okay. Well done. So look at this X-ray. There's a little bit more going on than in the usuals or in the others. But just tell me what you think and what your management plan would entail. She's 4 now, if I recall correctly.
Okay, so just going over it grossly, the most apparent thing is the leg length discrepancy with the abnormality of the right femur. Just sort of going back to our talks, I'll look at the right-hand image mainly and look at that left hip. So that acetabulum is dysplastic. I can see that the proximal femoral head is mostly uncovered. So that's a high acetabular index she's going to have. The rest of the, I would say on the femoral side, things actually look quite normal. And then just looking at her right hip, degree of coxa vera going on there, also with acetabular dysplasia. And yeah, otherwise I can't comment too much more about the hips here. So I think I missed, how old did you say she was?
4.
Okay. Yeah, so 4 years old. Yeah, we need to intervene. So focusing down on the hips, we need to address the, so go through the algorithm. So thinking open reduction, make sure we've eliminated any blocks to reduction, intracapsular, extracapsular, and then moving on to pelvic osteotomies. So
is the hip dislocated? The left hip?
no, subluxed.
It's not even subluxed. I mean, Shenton's line's intact. It's uncovered, true,
Fair enough.
and there's acetabular dysplasia, but it's not dislocated, so you don't have to do open reduction.
Okay, fair enough. Yeah, running away with it there.
No, that's fine. Under different circumstances, you would have been correct. But this,
Okay.
like I said, this is a slightly more complicated one. There's a lot more going on here than just DDH, but it's more fun.
Yeah.
Yeah.
Okay.
Okay, yeah, so go back. The acetabular dysplasia, correct? So you need to address that.
Yeah. So we definitely need to address that. That hip's probably it's gonna keep migrating. If it's subluxed now, it'll probably be dislocated if we left it there. Yeah, so we need to look at pelvic osteotomies, considering whether we're going to do just a rotational. So we're going to think something like a Salter, or are we going to move down the other arm and think things like the Dago and the Pemberton?
Then what do you think about the leg length discrepancy and that coxa vera on the right? If you had to like diagnose the right femur, what do you think's going on there? If you don't know, it's okay. Then you can ask a friend for help. But you've got coxa vera and
Yeah.
shortening of large shaft, isn't it?
It's going to be a bit of guesswork. Maybe a friend can offer some insights.
Okay. Let's go back to what's if I only show you that picture, ignore the left hip now. What's going on the right side there? What would your diagnosis be based on that X-ray picture?
I mean, so yeah, coxa vera. I don't know if it's like a fibrous dysplasia type pattern of that hip. I'm not too sure. It's got that bowing of that femur, and that's a typical coxa vera on the right. So I would say what fibrous dysplasia.
So I'll point out the features for you. So there's shortening of the entire femoral shaft of the diaphysis. There's mild coxa vera. So the neck shaft angle isn't that low. It's like 130 or whatever. And then there seems to be a little bit of valgus in that knee. So now you've got knee valgus, a short femur, and coxa vera.
Or PF50.
Yes, exactly. So I think she's got a unilateral PF50 or congenital short femur, which is kind of the same condition, just the various different spectrum. I'm not so sure about that valgus knee, I must say, but it is quite common in your fibulae mammalia and PF50s and so on. She doesn't have a clear fibulae mammalia, but there is shortening of that entire limb with the short femur and the coxa vera. So she's a funny little one. She's also quite dysmorphic, and she's had like cardiac anomalies and, you know, like one of those with a list of X-rays like this on packs of which none are orthopedic. So it's probably a bit of a backdraw situation, but yes. And then just as a closing statement, and this is, it might be more theoretical than anything else and not really proven, but there is this concept of long leg dysplasia. And if you look at her pelvis, the pelvis is tilted towards the side of the short leg, which is effectively uncovering the left hip. And with that, you get eccentric weight bearing on the roof of the acetabulum and the whole vicious cycle of hip dysplasia. So my concern for this patient actually, and she's booked for surgery at the end of the month for acetabuloplasty, is that the dysplasia will recur because of a leg length discrepancy. So she's too young to actually do anything surgically for that, maybe correct the valgus, but other than that, there's not much I can do. But that's just something to think about, because that pelvis remains oblique like that, then she's still going to eccentrically load the acetabulum on that side. Anyway, so, oh yeah, and this is just, you know, my typical mea culpa situation. It doesn't always work out well. I mean, these are difficult cases to manage the older they get. So that's why universal screening is probably a good idea. But then we never have to talk about it again. The take-home messages is early identification and treatment, of course, age-appropriate management, give a high enough surgical dose, and don't skimp on what you need to do. If there's a stabular dysplasia, do an osteotomy. Don't wait for things to correct on their own. Ongoing monitoring post-surgery to detect late complications, such as your type 2 AVN specifically. And then long conversations with the parents that they can understand, you know, that there's substantial risk of complications in these patients. And then this is just a cute little video to show you that the spica isn't necessarily the prison sentence that people think it might be. I mean, children are extremely resilient, and I've often seen kids crawl up stack boards, whatever, with their spicas. And this particular one actually walks. You'll see now. Okay, while we look at the video, if there are any questions, look at that. If there are any questions, please.
Maybe just one quick one, Anria. So you did give some sort of age cutoffs and so on there. So I was just wondering, ideal situation, you know, the child is picked up early, you go through your Pavlik time, let's say it takes a couple of months, you think you've got your numbers all right, so you do 6 more weeks, and then things fall apart. So I'm just sort of thinking of a timeline. When is your cutoff for I need to intervene now surgically? So I'm just sort of thinking around the plasticity around, in these young children, when do you say, well, there's no point trying to put it back in now, I need to go and do some form of reconstruction now?
Yeah, I think the question what you're asking me is, until what age can you rely on remodeling to correct the dysplasia once you've reduced the hip? Is that your question?
Yes, thank you.
Yeah. So maximum 2. So there's some evidence already from 18 months onwards, is that acetabular remodeling is not what we want it to be. It's not enough. So from the age of 18 months onwards, I start considering pelvic osteotomies quite strongly, but I'd say 2 and above definitely.
Okay, great.
Yeah. I think I have an article somewhere that proves that fact. I'll see if I can find it for you. Remind me. Okay. Then I'm going to call it a night. I'm actually quite impressed with the turnout, considering that tomorrow is a public holiday.